Transosseous pullout repair of the medial meniscus posterior root is indicated for acute or chronic medial meniscus root tears in patients with repairable meniscal tissue and maintained cartilage status. First, a diagnostic arthroscopy is performed to assess the type of root tear, cartilage status, and concurrent pathology. In a typical medial meniscus root tear, the posterior horn is detached 3 to 5 mm medial to its tibial root insertion. Then, the native root attachment site and the degenerated meniscal edges are debrided using a curette and a shaver. With the knee flexed, a root-specific tibial aiming guide is inserted through the anteromedial portal and positioned on the prepared root footprint. A guide pin is drilled from the anterolateral tibial cortex to exit precisely at the anatomic root site under direct arthroscopic visualization. The pin is then overdrilled with a 4.5 mm cannulated drill to create the transosseous tunnel. The drill is withdrawn, and a guide wire with a looped shuttle suture is passed through the tunnel using a wire retriever or suture passer. The suture loop is pulled from the tibial tunnel into the medial compartment. The posterior horn of the medial meniscus is then reinforced through this loop using an all-inside meniscus implant. The fiber stitch implant is particularly suitable for this purpose, as it leaves a suture loop outside the joint after deployment of the soft anchor within the meniscal tissue. By pulling on this loop, the first locking stitch of the implant is secured. A suture tape can then be threaded through this external loop and advance toward the posterior horn by pulling on the single traction suture, thereby closing the loop. In this way, the posterior horn of the medial meniscus can be stabilized in a simple and robust manner with strong suture material. Finally, by pulling on the blue loop of the transosseous suture, the reinforcement sutures are shuttled through the tibial tunnel and tied securely over a button on the anteromedial tibial cortex. Optionally, a centralization suture can then be added, and in case of a varus deformity, the indication for an osteotomy should be considered. Postoperatively, the patient is mobilized with non-weight bearing for 6 weeks.